Great slides.
So hi to all the viewers. So now we will have the discussion of the Allied Test Module 1, which had 25 questions from adrenal and pituitary gland. And we will have a detailed discussion with discussion of the previous year as well as the potential future questions for the upcoming NEET SS examination. So coming to question number 1, a 33-year-old female who is 2 months postpartum presented with headache and blurring of vision. So the important points I would highlight in this question: 2 months postpartum with headache and blurring of vision. The MRI of Sella had shown diffuse enlargement of the pituitary. That is the second most important point, diffuse enlargement. And which of the following is not true regarding the condition she is suffering from? Now, you must have had an idea. In a postpartum female with diffuse enlargement of the pituitary gland, you should think of the possibility of hypophysitis. Okay. So what do you mean by hypophysitis? It is the enlargement or inflammation of the pituitary gland, and the scenario of the condition occurring in the postpartum period makes you think of the possibility of lymphocytic hypophysitis. So essentially the question is, which of the following is not true regarding lymphocytic hypophysitis? First option, it has an autoimmune etiology. It is actually a true option. Second, ACTH deficiency is the most common hormonal abnormality. By and large, it is ACTH, but there are certain reports which have indicated that gonadotropins or even TSH could be the most commonly involved. But the majority of the literature points to the fact that ACTH is the most common hormonal abnormality. That again is a true statement. Then vasopressin deficiency is likely to be permanent. Very, very important question. So you can have any hormone deficiency in a patient with hypophysitis. Could be ACTH, TSH, prolactin, etc. But once the vasopressin or the ADH is deficient, it is less likely to recover, whereas all the other hormonal axes may have a chance to recover once the inflammation subsides. So vasopressin or diabetes insipidus, once it sets in, it is more likely to be permanent because it is associated with the neuronal cell death. Okay, so this is also a true statement. And the fourth option, it is exclusively occurring in pregnancy and postpartum period. That is the wrong statement. Even though the classical scenario is linked with a woman in the third trimester or in the first 3 months postpartum, only 2/3 of all the cases of lymphocytic hypophysitis is reported in the pregnancy or postpartum period. The remaining 1/3, even though it has a predilection to the females, it may occur outside the setting of pregnancy and postpartum period. So the answer for the question is option D. And you can learn a few more points with regards to hypophysitis. The types based of histology, they include lymphocytic. Then you have granulomatous. You have IgG4 related. You have xanthogranulomatous. And finally, necrotizing. So these are the histological types of hypophysitis, and based on etiology, you can divide it into autoimmune, again, granulomatous, infiltrative, then infective, drug-induced, etc. So these are the types of hypophysitis based on its etiology. Now, a points regarding to lymphocytic hypophysitis. The lymphocytic hypophysitis is further classified based on the anatomy of involvement. It can be classified into adenohypophysitis, infundibuloneurohypophysitis, and panhypophysitis. Adeno means just the anterior pituitary alone. Pan means both the anterior stalk and posterior pituitary. Infundibuloneuro means just the stalk as well as posterior pituitary involvement. And predilection, we have discussed, it is in the last trimester of pregnancy and in the first 3 to 6 months postpartum, which is the most common period where lymphocytic hypophysitis cases have been reported. The most common hormone involved is ACTH followed by TSH. This is what is given in the standard textbooks of endocrinology. And regarding presentation, the presentation of hypophysitis could be due to 2 points, either due to mass effect or it could be due to hormone deficiency. So the mass effect can be in the form of headache, visual disturbances, and the hormonal deficiency. So hormone deficiency in the form of ACTH, TSH, and rarely gonadotropic deficiency as well. Now, as we have discussed, the important differential diagnosis of lymphocytic hypophysitis is the pituitary adenoma. So how to differentiate pituitary adenoma from lymphocytic hypophysitis? It is by a radiological scoring called Gutenberg scoring. So Gutenberg scoring is a radiological scoring to differentiate between lymphocytic hypophysitis and pituitary adenoma. You can just go through the important points. You can see the symmetrical gland enlargement in lymphocytic and asymmetrical in pituitary adenoma. The stalk position is central in lymphocytic hypophysitis and it is deviated in adenoma because it is asymmetrical. The posterior pituitary signal is lost because the stalk and posterior pituitary is commonly involved in lymphocytic hypophysitis, whereas the diabetes insipidus per se is a very, very rare feature in a patient with pituitary adenoma. And the enhancement also, there is avid and diffuse enhancement of lymphocytic hypophysitis involved pituitary, whereas the pituitary adenoma is less enhancing compared to the normal pituitary with regards to a pituitary adenoma. So this is how you differentiate between hypophysitis and its close mimicker pituitary adenoma. So it is diffuse enlargement and homogeneous contrast uptake in hypophysitis with involvement of stalk and symmetric involvement in hypophysitis, whereas asymmetric with no stalk involvement and non-enhancing in a patient with pituitary adenoma. So regarding the management, we have discussed 2 problems with hypophysitis. One is the mass effect and second is the hormonal deficiency. So in a patient with significant mass effect in the form of headache and visual disturbance, if the patient has mass effect, then you can use IV steroids or high-dose oral steroids. High-dose oral steroids. That means prednisolone at a dose of 40 to 60 milligram per day can be given for 6 to 8 weeks upfront. Whereas if there are no mass effect, just hormone deficiency alone, you can give the replacement dose of hormones whichever is deficient. That means glucocorticoids for ACTH deficiency and thyroxine for TSH deficiency. So this is how you approach a patient with lymphocytic hypophysitis and eventually manage them. So coming to the next question, which of the following is not a true statement regarding craniopharyngioma? So craniopharyngioma, as you know, is the most common cellular supracellular tumor in children. So the first option, it is derived from Rathke's pouch remnant. So it is a correct statement. It in fact is derived from the Rathke's pouch epithelial remnant. And adamantinomatous variant is more common in children. You know, there are two variants for craniopharyngioma. Adamantinomatous more common in children, and papillary is more common in adults. So again, that is a correct statement. It is radiosensitive in most cases. Again, that is quite an ambiguous statement, to be fair, because the adamantinomatous variant is more sensitive to radiation and papillary variant not so. But if you look at the overall proportion of adamantinomatous and papillary, adamantinomatous is the most common variant overall. So hence, you can say that it is radiosensitive in most cases. So again, that is the correct statement. If you look at the fourth statement, BRAF inhibitors are used in the management of adamantinomatous craniopharyngioma. That is the wrong statement. So why is it so? We will just learn. So craniopharyngioma types we have just discussed. It can be adamantinomatous and papillary. Adamantinomatous and papillary. If you look at the individual points with regards to each of these variant, this adamantinomatous is more common in children, and it can even occur in elderly also, in adults also. But papillary occurs exclusively in adults. Now, what are the other attributes of this variant? It is aggressive. It is more aggressive than papillary, and there is increased risk of recurrence. Okay. Then it has cystic solid appearance, solid cystic appearance with calcifications and presence of machinery oil or cholesterol-laden fluid content within the cyst. We call it as machinery oil content. Machinery oil content. So any of these can be asked as a potential MCQ. So machinery oil content, the presence of calcification, cystic nature, aggressive nature, everything is associated with adamantinomatous craniopharyngioma. And papillary craniopharyngioma, it is more solid. It exclusively occurs in adults, less aggressive, but it is less radiosensitive also. So if you are having an advanced variant of papillary craniopharyngioma, you have less therapeutic options, whereas adamantinomatous is radiosensitive, but even if it responds to radiotherapy, there is increased risk of recurrence. And what about the mutations? So mutation in papillary is BRAF. The BRAF mutation is present in papillary. And what is the mutation in the adamantinomatous variant? It is the catenin B1 or the CTNNB1 mutation in adamantinomatous. So consequently, in patients with non-resectable papillary craniopharyngiomas, BRAF inhibitors like vemurafenib, dabrafenib have been tried, whereas the catenin inhibitors are in the pipeline for as an adjuvant management in a patient with adamantinomatous craniopharyngioma. So these are the important points with regards to each of the variant. So mutations we have discussed, and regarding the management, the standard management protocol is surgery plus radiation. Surgery plus radiation, and of these, adamantinomatous is more responsive to radiation, and it is not often curative because this is a locally aggressive lesion. It will have it infiltration into the hypothalamus, maybe into the midbrain region, into the adjacent cortical lobes, maybe into the cellular region and paracellular region to the cavernous sinus. So surgically removing them in toto is not often possible. And even the adjuvant radiation that you are administering also may help to reduce the mass effect, especially in the visual tract pathway as well as in the hypothalamus, but it is usually not curative and there is increased risk of recurrence also. And panhypopituitarism is also very, very common. And one more question with regards to the hormonal involvement in craniopharyngioma is that growth hormone is the most common deficiency. Growth hormone deficiency is the most common hormonal abnormality. And the second point is that diabetes insipidus is present in around 20 to 30%. And when the patients undergo surgery, the risk of diabetes insipidus can increase as high as 60 to 70%. So in a treatment naive patient, it is up to 20 to 30%, and following surgery, it can increase up to 2/3 of individuals. So coming to the next question, which of the following statements regarding the development of adrenal gland is not true? So a false statement regarding adrenal gland development. So first option, adrenal cortex takes its origin from intermediate mesoderm. That is a correct statement. Intermediate mesoderm give rise to adrenogonadal primordium. Adrenogonadal primordium, which eventually splits off into the primitive adrenal gland as well as the gonads. So intermediate mesoderm is the precursor for this adrenal gland development. And the next option, in the fetus, adrenal medulla is as large as cortex, which is a false statement. The adrenal cortex is always larger than medulla throughout the period of gestation. Then the third option, the fetal zone of the adrenal gland secretes androgens. Very, very important point, and that is a true statement also. The fetal adrenal gland has two layers. One is the fetal zone and the definitive zone. So you have the fetal zone and the definitive zone. So fetal zone is responsible for secretion of androgens, and the most important androgen produced in utero by the adrenals is DHEAs. And the definitive zone becomes active only after the second trimester, when the third trimester sets in, and it can produce aldosterone and a more differentiated area within the definitive zone, which we call as the translational zone, that produce cortisol as well. So definitive zone, it produces the aldosterone, fetal zone produces the androgens. So zona reticularis is not developed in utero. That again is the correct statement, because only there are two major zones, the fetal and definitive. Once the child is born, the fetal zone will start to involute, and only after that complete involution of fetal zone, there will be precursors of zona reticularis development, and the development occurs only by 2 to 3 years. So only by 2 to 3 years after birth, the development of zona reticularis occur, and it is complete only by around 10 to 20 years. So the development by 2 to 3 years, maturation by 6 to 8 years, and complete development by 10 to 20 years. That is about zona reticularis. So development of adrenal gland, we had seen its origin, intermediate mesoderm, giving rise to adrenogonadal primordium. And which are the important transcription factors which are responsible for adrenal gland development? They include SF1, DAX1, WT1, etc. These are some of the important transcription factors for adrenal gland development. And the zones we have discussed, the fetal, transitional, and definitive. Of these, fetal and definitive are the most important. Transitional zone can have a role in the secretion of cortisol. So this is the diagram from Williams Endocrinology. So here the intermediate mesoderm, it gives rise to urogenital ridge, which gives rise to adrenogonadal primordium, which splits off into adrenal as well as gonadal primordium. And here you can see medulla is always smaller than the cortex, both in the intrauterine period as well as in the postnatal period. And it has two zones, definitive zone and the fetal zone. Fetal zone lies inner to that, and definitive zone is in the outer part of the cortex. So the next question regarding pituitary adenoma, you want to identify the false statement. So majority of non-functional pituitary adenomas are gonadotrophs adenoma. That is the first option. That again is a correct option, because the gonadotroph adenoma may produce excess of the alpha subunit of LH and FSH. Only when active alpha and beta subunits are produced together, they will have a functional hormone. So when the isolated subunit production is there, which is excessive, there will not be a hormonal consequence, due to which many of these adenomas, gonadotroph adenomas, will be hormonally silent. There will not be any clinical consequence. So they would just present as a non-functional adenoma. Only when you resect it out and when you do the hormonal staining, you will identify that it is in fact a gonadotroph adenoma. So majority of non-functional pituitary adenomas are in fact gonadotrophic adenomas. Now, what is null cell adenoma? So null cell adenoma means everything is negative. The hormonal staining is negative. Transcriptional factor expression is also negative. You know that the current WHO classification of pituitary tumors stems from the transcriptional factor-based classification. So which are the tumors derived from PIT1, which are the tumors derived from TPIT, which are the tumors derived from SF1 and GATA2, like that. So null cell adenomas means no transcription factor staining, no hormone staining. But here the statement is mentioning that the null cell adenomas have transcription factor of origin, which is actually a false statement. So this is the answer for our question. We'll just see the other options also. The TSH producing adenomas are usually macroadenomas. Again, that is a correct statement. So which among the functional adenomas are macro, which are micro? TSH, GH, and gonadotroph. These are the macroadenomas. The ACTH and prolactin. These are microadenomas. Why these are microadenomas and why others are macroadenomas? Because the clinical features of acromegaly is only slowly progressive and may not be readily apparent until later stages. Similar is the case with TSH producing adenomas. The degree of thyroid hormone elevation may not be that dramatic in a patient with TSH producing adenoma. Hence, there will be a long latent period before actual clinical diagnosis is made. In fact, in many of these cases, the diagnosis is apparent only when they present with mass effect or features of raised intracranial tension. Whereas in a patient with prolactinoma, especially in females, they would readily have galactorrhea, for they would seek the hormone, the medical attention, and they would diagnose the prolactinoma at the initial stage itself. Same with ACTH producing a pituitary adenoma, even though there may be a bit of latency, but they will present with florid clinical manifestations leading to early diagnosis. And there are certain genetic causes, like the mutation-related causes, as to why ACTH producing adenomas are usually microadenomas, which I'm not going into the details because it is beyond the scope of our current discussion. And corticotroph adenomas doesn't always result in Cushing syndrome manifestations. It's of course, a correct statement because there is an entity called silent corticotroph adenoma. Silent corticotroph adenoma means the patient, when they are resected off the lesion, it would show TPIT transcription factor and ACTH hormone positivity. But when you look at the biochemical evidence of cortisol excess by an ONDST or a salivary cortisol, it would be negative. No biochemical clinic cortisol excess, no clinical features of cortisol excess, just the tumor specimen will show ACTH staining. They are called as silent corticotroph adenoma. So all corticotroph adenomas doesn't result in Cushing syndrome manifestations. So the correct answer for our question is option number 2. So the points in the new WHO guidelines we have discussed in our long videos, they are currently termed as pituitary neuroendocrine tumors, and they are classified based on their transcription factor of origin, whether it is PIT1, TPIT, or SF1. And null cell tumor means they are negative for all transcription factors and hormones. And one more potential question is, when you are having a large pituitary mass, it appears as a large pituitary, you are not sure whether it is an adenoma or just a hyperplasia, the histopathological staining that helps you to differentiate between the two is the reticulin staining. Okay, so if the reticular framework or the reticular pattern is disrupted within the pituitary, that is likely to be due to pituitary adenoma, whereas the hyperplasia occurs as proliferation of the cells with intact reticulin framework. Okay, that is very important point. So this classification, I am not going into the detail, which we have discussed in the long videos. All lineage, PIT1, TPIT, SF1 lineage tumors, etc. So coming to the next question, a 43-year-old male with resistant hypertension is being evaluated for primary hyperaldosteronism. Which of the following medications will not alter the result of the screening investigation she is gland to undergo. Okay, so just a straightforward question. The drug which doesn't interfere with the ARR, aldosterone renin ratio. Now, just look at each drug one by one. First, clonidine. So, for a drug to alter the aldosterone renin ratio, it has to interfere with the renin angiotensin aldosterone system. Okay, either the renin production or the aldosterone production or the aldosterone action. Now, what does clonidine do? So, clonidine is an alpha-2 agonist. Alpha-2 agonist. You know that alpha-2 is a presynaptic receptor, and the stimulation of alpha-2 receptor will cause reduction in the sympathetic stimulation. Reduction in the sympathetic stimulation. So, this sympathetic stimulation is one of the potent regulator of renin secretion. So, when there is reduced sympathetic tone, there will be reduced renin. Reduced renin. So, what happens to the aldosterone renin ratio in a patient who is taking clonidine? There will be reduction of renin and there will be increase in the aldosterone renin ratio, leading to a false positivity. So, clonidine result in false positive. False positive. So, it does interfere with the testing, and you should not do it the testing while the patient is receiving clonidine. So that is our first option. Now, what about nebivolol? Okay, nebivolol. So nebivolol, as you know, is a beta blocker, right? So beta 1 receptor is expressed in the juxtaglomerular apparatus. So which the beta 1 stimulation actually increases renin. So what will a beta blocker do? It will reduce renin. So nebivolol would reduce renin. And when the renin is reduced, what will happen? There is increase in the aldosterone renin ratio, leading to false positivity. So clonidine produces false positivity, and nebivolol also produces false positivity. Now look at losartan. What will losartan do? Losartan is an angiotensin receptor blocker. So angiotensin receptor blocker would lead to reduction in the conversion or reduction in the angiotensin 1 action, leading to a consequent feedback, loss of feedback inhibition on renin, causing an increased renin levels. So losartan, it reduces angiotensin 81 action, which causes an increased renin. So there will be a compensatory increase in renin levels, due to which there is false negative ARR. Okay. So among the options, the 4 options, the clonidine causes false positivity, nebivolol causes false positivity, losartan causes false negativity, and it is the non-dihydropyridine calcium channel blocker, which is diltiazem, that doesn't interfere with aldosterone renin ratio. So the drugs that can be used while testing ARR include non-dihydropyridine CCBs like diltiazem, then alpha-1 blockers like prazosin, and direct vasodilators like hydralazine. So these are the antihypertensives that doesn't interfere with the ARR testing. Now, a 34-year-old female who is a mother of 2 children with history of blood transfusions during last childbirth has presented to you with increased fatigue and amenorrhea. Which of the following is not true regarding the condition she is suffering from? So here, just like the hypophysitis case we have discussed, here this is a woman who has had history of blood transfusions owing to postpartum hemorrhage. So a woman with postpartum hemorrhage now presenting with fatigue and amenorrhea. Okay, fatigue, by extrapolating the clinical situation, you can assume it is due to glucocorticoid deficiency, and amenorrhea due to gonadotropin deficit. So linking all these pointers together, the likely diagnosis is Sheehan syndrome. Okay, Sheehan syndrome, which is the postpartum pituitary necrosis. So we want to identify the false statement regarding Sheehan syndrome. So MRI shows empty cella is of course a correct statement. Either a partial or a total empty cella may be apparent. Growth hormone and prolactin deficiency are most common. In fact, growth hormone deficiency is even more common than prolactin. But you must have learned that prolactin deficiency is characteristic, or postpartum failure of lactation is characteristic of Sheehan. It's because the abnormalities of prolactin levels are more clinically apparent, whereas growth hormone deficiency may not be that easily clinically evident. They will have only long-term implications. So if you check biochemically, growth hormone deficiency may be more common than prolactin. So if you combine this, GH plus prolactin is the most common combo which is deficient with regards to anterior pituitary hormones in Sheehan syndrome. Third option, the patient may present with hyponatremia and hyperkalemia. It's a wrong statement. Why hyperkalemia is not there? In a patient with adrenal insufficiency, it could be either due to primary or secondary adrenal insufficiency. So primary AI will have aldosterone deficiency, whereas secondary AI will not have aldosterone deficiency. It is the aldosterone deficiency and not the glucocorticoid deficiency which results in hyperkalemia. You know that secondary AI, as in the case of Sheehan, will have normal RAS activity due to which the potassium levels will be kept as normal. The hyponatremia is contributed by both glucocorticoids and mineralocorticoids. So hyponatremia in Sheehan is a true statement, but hyperkalemia in Sheehan is a false statement. And diabetes insipidus is very rare because the posterior pituitary has a better blood supply with higher oxygen saturation compared to anterior pituitary, due to which the posterior pituitary necrosis is less common, and consequently diabetes insipidus is also rare in a patient with postpartum anterior pituitary necrosis or Sheehan syndrome. So a few points we have discussed previously regarding to Sheehan. The most commonly involved cell lines are GH and prolactin. Failure of lactation is the most specific clinical manifestation. Secondary adrenal insufficiency, the patient would have less likelihood of hypotension and hyperkalemia due to intact aldosterone axis. Least common hormone deficiency is vasopressin, and there may be a very long latent period before this becomes clinically apparent. And Simmons disease, it was the terminology which was given in the initial part in the 1930s and 1940s. It described panhypopituitarism due to any cause. Okay. Now, a very, very important clinical question. A 42-year-old male presented with restlessness and tremors of 2 years duration. His thyroid function test is TSH of 2.1. Total T4 definitely is elevated. Total T3 is elevated. Free T4 is elevated above the upper limit of normal. So high thyroid hormones, T3, T4, and free hormones are elevated. But in a patient who is having thyrotoxicosis or hyperthyroidism for that matter, if you want to identify from where the thyroid hormone is getting stimulated, whether it is an intrinsic thyroid disorder or whether it's from the stimulation from the pituitary, the answer depends on your TSH levels. Because the TSH and thyroid hormones have an inverse logarithmic relation between them. Even a very small increase in TSH or T4 would lead to a sudden reduction in the TSH levels. That means the nutshell is that when your T4 or T3 becomes even slightly above the upper limit of normal, the TSH would already be suppressed in a patient who is having primary hyperthyroidism, as in a Graves' disease or toxic multinodular goiter. So there are situations where the patient would be having elevated T3 or T4 with non-suppressed TSH. TSH is not suppressed. That means the stimulation is not coming from within the thyroid, it is coming from elsewhere. And where is that elsewhere? It is from pituitary. So if the cause for hyperthyroidism results or resides at the level of pituitary, you would have non-suppressed TSH with elevated T4 and T3. And which are the two important causes? TSH producing adenoma, and thyroid hormone resistance. So these are the two important conditions where T3 and T4 could be elevated with non-suppressed TSH. So why in thyroid hormone resistance the TSH is non-suppressed? Because the thyroid hormone resistance is actually a genetic condition where there is inactivating mutation in the thyroid hormone receptor beta. You know that two isoforms or receptors are there, alpha and beta forms of thyroid hormone receptors. Beta is the one which is present in pituitary and at the level of liver. At the level of pituitary, this beta receptor mediates the feedback inhibition. That means the elevated T4 and T3 exerts feedback inhibition to reduce TSH at the level of pituitary by acting on thyroid hormone receptor beta. So when that beta is defective, what happens? The TSH will not be suppressed despite having a high T4 and T3. So that is the reason for the non-suppressed TSH. Now, what is the role of this ferritin and SHBG in a patient with this clinical profile? So thyroid hormone receptor beta, I've told it's present in pituitary and in the liver. In the liver, thyroid hormone acts via the beta receptor to increase the ferritin, to increase the SHBG. So what would be the ferritin and SHBG level in a patient with thyroid hormone resistance? It will not be elevated because of the mutant receptor. Whereas in a patient with TSH producing adenoma, they would have high T4 and T3 in the circulation with an intact beta receptor at the liver, resulting in increased ferritin and SHBG. So the answer for our clinical question, the diagnosis what we have mentioned is TSH producing adenoma and not thyroid hormone resistance. So which is the preferred management option for TSH producing adenoma? Options include methimazole, propyl thiouracil, diiodothyropropionic acid, and octreotide. The answer is octreotide because the TSH producing adenoma express so much of somatostatin receptor 2. And the octreotide binding to somatostatin will result not only in reducing the TSH concentration, but also reduces the proliferation of the thyrotroph cells. Now, what about methimazole and propyl thiouracil? The role of ATDs in a patient with TSH producing adenoma, they may be used in crisis situations, like the patient is having severe thyrotoxicosis, because octreotide may take a few days to act. In that time period, you may use methimazole and propyl thiouracil. But why we are not using it for long term is because when you are further reducing the T4 and T3 levels with methimazole and propyl thiouracil, there is a theoretical loss of whatever feedback inhibition that is left at the level of pituitary. So TSH producing adenoma is already a macroadenoma which could be impinging on the optic tract, optic chiasma, and the optic nerves. Okay, so when you are treating it with methimazole and propyl thiouracil, the feedback inhibition on that tumor by the thyroid hormones is lost, due to which there may be a risk of tumor expansion and worsening of mass effect. That is why you are not using antithyroid drugs upfront, where if you are using octreotide, that would cause a reduction in the tumor mass itself and a further reduction in the TSH production, which will cause a reduction in the T4 and T3 levels. That is why octreotide is the medical treatment of choice. Of course, the definitive treatment is surgery, but if you're asking in a post-surgical patient, which is the best medical option, the answer is definitely octreotide. Now, which of the following is not true regarding cabergoline therapy in a patient with prolactinoma? So, preferred treatment even in patients with visual symptoms. That is a correct statement. This is the only pituitary tumor variant where even in a patient who is having mass effect in the form of visual symptoms, you would try medical therapy upfront, because the pituitary adenoma, which is prolactinoma, express a lot of D2 receptors, dopamine 2 receptors, and stimulation of these dopamine receptors would cause a reduction in the tumor size and normalization of prolactin. So rather than going for surgery, cabergoline would be the preferred treatment in such situation. Valvulopathy in cabergoline therapy is due to the cross-reactivity of the molecule with the serotonin 2B receptor. That is again a true statement. And it can result in impulse control disorder. Very, very true, because in patient with schizophrenia and psychotic disorders, it is the dopaminergic hormone overactivity. That is why you use dopamine blockers, D2 receptor blockers in patients with psychosis. So if you are giving dopaminergic agent, there may be risk of psychotic outbreaks and impulse control disorders, which is again a true statement. And may consider stopping after 1 year of therapy. It is not the cumulative duration which is important. You have to make sure that the tumor has disappeared or there is more than 50% reduction and the prolactin has normalized and the duration of therapy is at least 2 years. So you have to make sure that at least 2 years of treatment you are given and the tumor has disappeared and the prolactin is normalized. Only then you will consider stopping cabergoline therapy. So this is the wrong statement. Now, coming to the next question with regards to the prolactin. A 24-year-old female presented with 6 months of amenorrhea now reports milky discharge from the breast for 3 weeks. So these are the hard signs for hyperprolactinemia, galactorrhea and amenorrhea. But surprisingly, you expected the prolactin levels to be very high, but the level was 8 nanogram per ml. That is actually very low. So normal prolactin level in a female is less than 25 nanogram per ml. So it is well within the normal limit. And this MRI showed a mass lesion in the cellular region. So everything is fitting and is suggestive of a macroprolactinoma except the prolactin levels. So which is that situation where you get a spuriously low prolactin in the setting of a definitive clinical setting of macroprolactinoma? That is hook effect or prozone phenomenon. So how do you ameliorate this hook effect? It is by repeating the test under serial dilution. So option D is the correct answer. You should repeat the test with serial dilution to get the correct prolactin value. And if you look at the other options, symptoms with normal prolactin could be due to stalk effect. The stalk effect means the tumor is impinging on the infundibulum, thereby reducing the dopaminergic surge into the anterior pituitary, causing an increase in the prolactin levels. Large immunoglobulins bound to prolactin result in macroprolactin. Macroprolactin means high prolactin values with no clinical symptoms. Gel filtration chromatography would be the best thing for actual prolactin level. That is a false statement. Gel filtration chromatography is to correct the macroprolactin and not the hook effect. And for hook effect, you should repeat the testing on serial dilution, which is the answer for our question also. So a straightforward question, direct pick from Harrison. The order of hormonal failure associated with pituitary compression or destruction. So this is the answer. The growth hormone is the most susceptible one, followed by FSH, TSH, and ACTH. So in all the conditions, usually in pituitary condition, pituitary compression, pituitary loss of vascularity, or in radiation-induced damage, the growth hormone followed by gonadotropes, followed by TSH and ACTH is the most common pattern. Probably one of the very few scenarios where this order is not followed is hypophysitis, which we have already discussed, especially in drug-induced hypophysitis. I've told you that in certain cases of lymphocytic hypophysitis, even though ACTH may be very commonly involved, sometimes it may be spared and the other hormones can be involved more than ACTH axis. But in drug-induced hypophysitis, it is almost always the ACTH, which is the most common and the earliest hormone that is involved. Okay. So in all other situations, growth hormone followed by gonadotropes are the cell lines which are easily susceptible. Next question. A 43-year-old male with history of pituitary adenoma underwent transvenoidal surgery and is on hormone replacement for panhypopituitarism. So what we are dealing with is a post-op patient with panhypopituitarism. And the patient had growth hormone deficiency and he was started on daily growth hormone injection. So once you start the patient on growth hormone injection, what changes should you make to the other hormone replacement? So that is the question. So what is the impact that the replacement dose of growth hormone acts on other hormonal axis? Now look at HPA axis. That means the cortisol impact. So what is the effect of growth hormone on cortisol? The growth hormone, it increases IGF-1. Okay, so IGF-1 has an inhibitory effect on 11 beta HSD1. 11 beta HSD1. So what is the function of 11 beta HSD1? It is the conversion of cortisone to cortisol. So the cortisol generation is affected by 11 beta HSD1 inhibition by IGF-1. So what happens? There will be increased requirement of cortisol in a patient who is on GH replacement. So the correct answer is increase hydrocortisone dose. You should increase the steroid replacement dose in a patient who is receiving growth hormone. Now, what about the other axis, thyroid axis? So growth hormone can have two actions. It can increase T4 to T3 conversion, and it can reduce TSH as well. Why does it reduce TSH? Growth hormone administration would increase the somatostatin tone, and the somatostatin stimulation would reduce the TSH production from the pituitary. So it can precipitate central hypothyroidism. Central hypothyroidism. Okay, why? Because the TSH production is lowered. And the T3, the more of the T3 produced, which will exert more and more feedback induction, further reducing the TSH levels. So central hypothyroidism may ensue, and you may have to increase the thyroxine replacement also. So both thyroxine and cortisol replacement should be increased in a patient who is receiving GH. But here the increase of thyroxine dose is not in the option, rather reduction is there, which is a wrong statement. And growth hormone doesn't have notable effect on the gonadal axis or on the posterior pituitary or the ADH or vasopressin function. So the correct answer is hydrocortisone, but you should also remember the effect of growth hormone on the thyroid axis as well. Next question, which of the following is not a true statement regarding primary bilateral macronodular adrenal hyperplasia? So just the term, there is primary, that means it is an intrinsic adrenal disease. Bilateral means on the both adrenals. Macronodular, that means the nodules size more than 1 centimeter. So what are the conditions producing secondary bilateral macronodular adrenal hyperplasia? That means the stimulation is coming from elsewhere. Increased ACTH in the circulation. It could be part of congenital adrenal hyperplasia. It could be part of a Cushing disease where the ACTH is coming from the pituitary. Such situation can also produce bilateral macronodular adrenal hyperplasia, but it is secondary to circulating ACTH. Primary means the defect lies at the level of adrenal itself, and it is independent of the circulating ACTH. So it is an ACTH independent cause of Cushing syndrome. Very, very important. So you can just go through the statements. There may be increased intra-adrenal ACTH with normal circulating levels. Very, very true. The circulating ACTH is normal, but there can be conditions where the intra-adrenal ACTH levels may be increased or the downstream signaling of ACTH may be increased. But the levels of ACTH in the blood is always normal. It's a true statement. ARMC mutation is the most common genetic cause. Again, it's a true statement. Present in young adults with classical features of Cushing syndrome. That is a wrong statement, actually. Why? Because even though it may occur in young patients, it is more common in adult patients. And even though the size of the nodules are large, more than 1 centimeter, the functional capacity is reduced. So the glucocortic zona fasciculata is not very differentiated, and the cortisol production is actually less. So despite having a larger lesions, the hormonal production will be less, and the manifestations will not be overt. They will have subclinical Cushing and sometimes no features of Cushing at all. So the most common hormone produced is, of course, glucocorticoids, but the degree of overproduction is minimal. And the aberrant expression of LH, serotonin, GIP may be observed. It means that the adrenals express any of these receptors, the serotonin receptors, the GIP receptors may be there. And when the ligand binds to the surface of the receptors, a process similar to ACTH stimulation will happen. Serotonin binding to the serotonin receptors in the adrenal will lead to increased signaling and increased proliferation and steroidogenesis. So aberrant receptor expression is one of the classical features in primary bilateral macronodular adrenal hyperplasia. So we have learned about the points. The nodule size is more than 1 centimeter. Manifestation, we have learned Cushing is the most common manifestation, but it will be less florid compared to other causes of Cushing syndrome. Genetic basis, you will have to learn 2 important mutations, ARMC5, which is the armadillo repeat containing 5, ARMC, and GNAS mutation, which is associated with McCune-Albright syndrome. These are the 2 important mutations that can lead to primary macronodular adrenal hyperplasia. Pathophysiology, we have learned it could be intraadrenal ACTH or aberrant expression of other hormones and their receptors. And how do you treat? If the patient is having florid Cushing syndrome, even though both adrenals are involved, you resect the larger adrenal. Resect larger adrenal. And it has been shown that the removal or adrenalectomy of the larger side can result in remission of up to 90%. So you may think that for bilateral disease, you will have to do bilateral adrenalectomy, but in practice, the removal of the larger adrenal gland would lead to remission in almost all the cases. Okay. And other conditions where aberrant receptor expression is documented, you can use the targeted treatment. For example, there is something called as food-dependent Cushing syndrome. Food-dependent Cushing syndrome. Food-dependent Cushing means whenever the patient takes food, there will be increased GIP levels, which is an incretin. This will go and bind to the receptor in the adrenal, which will cause an increased cortisol secretion. Okay, so in such situation, how do you treat the patient? You will have to reduce the GIP secretion. And which is the agent to reduce the GIP secretion? It is octreotide. So octreotide is the treatment of choice for food-dependent Cushing syndrome mediated by GIP. Similarly, the serotonergic receptor mediated aberrant Cushing would be dealt with by serotonin receptor blocker. Then the LH receptor aberrant expression would be mediated by leuprolide or GnRH agonist to reduce LH secretion likewise. Okay. So next question, again a straightforward question. They arrange the causes of Cushing syndrome in the order of their prevalence. So just taking the data from Harrison, 75% from Cushing disease, 15% from ectopic ACTH, and 5 to 10% from adrenal adenoma, and less than 1% from adrenal hyperplasia, the macronodal adrenal hyperplasia and all that we have discussed. So the correct answer is first is Cushing disease, followed by ectopic ACTH, followed by adrenal adenoma. So this is the correct answer for our question. Now, the next question with regards to acromegaly, a 44-year-old male was diagnosed with acromegaly due to pituitary macroadenoma, underwent transvenoidal resection. Okay, acromegaly, the first line treatment is transvenoidal surgery, and the patient has underwent the same. The patient had persistently elevated IGF-1 levels and uncontrolled blood glucose despite being on monthly octreotide. So it is evident that the patient had residual disease post-surgery, and he had uncontrolled disease with activity. Therefore, the medical therapy was instituted with octreotide, and despite being on full dose of octreotide, the patient is still having uncontrolled disease. So basically, this patient is having uncontrolled blood glucose. So that is an urgent thing to be controlled. You just cannot give radiotherapy and wait for the 2 or 3 years to have for this activity to get controlled. You want something that acts immediately. So even though stereotactic radiosurgery would be a good option, but in this patient with uncontrolled blood glucose, you want something which a very short latency of onset of action. Radiosurgery typically takes 2 to 3 years for its definitive action and hormonal reduction. So stereotactic radiosurgery will not be the best option. Now, which would be the other options? Is it pasireotide? Is it pegvisomant? Is it paltusotine? Let's see what the recommendations say. So in a patient who has failed the primary medical therapy with either octreotide or lanreotide, you will have to look at these factors. Whether if the patient is having large tumor and your concern is the tumor, or if you are having impaired glucose metabolism as concern, or you are having both as their concerns. So in our patient, our concern is not the mass effect, but the uncontrolled blood glucose. Okay, in uncontrolled blood glucose, if you give pasireotide can worsen the hyperglycemia. Okay, even those who are not diabetic and is having acromegaly, if you start pasireotide, then 3/4 of them will become diabetic in the next 6 to 12 months. Okay, that is the severe and hyperglycemic effect induced by pasireotide. So in such patients with uncontrolled diabetes mellitus, difficult to control hyperglycemia, and who has failed octreotide therapy, pegvisomant would be our treatment of choice. And which condition would you use pasireotide specifically? If the tumor is there, which is already impinging on the optic chiasm. If you give pegvisomant, just like we have dealt with anti-thyroid drug usage in TSH producing adenoma, we have told that there is loss of feedback inhibition, which can theoretically increase the size of the lesion. Similarly, this pegvisomant is a growth hormone receptor blocker. So this growth hormone cannot exert feedback inhibition on the pituitary adenoma, due to which the pituitary adenoma can increase in size. So if the tumor size is the concern and you are worried about the mass effect due to the tumor, then you will not use pegvisomant. In such case, we will use pasireotide. Whereas if you have uncontrolled diabetes as your concern, then pegvisomant would be the best option. So the answer for our question is pegvisomant. So the next question, which of the following conditions does not result in significant adrenal enlargement? Okay, significant adrenal enlargement doesn't occur in which condition? Okay, star deficiency, we have seen it causes lipoid adrenal hyperplasia. Lipoid adrenal hyperplasia. Now, lipoid adrenal hyperplasia means there is massive enlargement of adrenals due to large lipid droplet deposition due to star protein deficiency. So definitely there is significant adrenal enlargement. Now, what does DAX1 mutation produce? We have learned in our module, it produces adrenal hypoplasia congenita. So there, DAX1 is one of the transcription factors required for proper adrenal gland development. So its inactivating mutation will result in a hypoplastic adrenals. So it doesn't result in adrenal enlargement. So the other conditions like 21 hydroxylase, it can result in adrenal hyperplasia. Ullmann disease is actually acid lipase deficiency. Acid lipase deficiency resulting in primary adrenal insufficiency and adrenal calcifications bilaterally. Okay, so the answer for our question is DAX1 mutation. So coming to the next question, which of the following is not true regarding the use of adrenal venous sampling in a patient with primary aldosteronism? First option, all aldosterone producing adenomas are not visualized on CT imaging. That is a true statement because lesions less than 5 millimeters in size may not be readily discernible in a CT imaging. So adenomas can have size as low as 2 to 3 millimeters in size. So such adenomas may not be visualized if you are doing a CT abdomen. So that is a correct statement. AVS or adrenal venous sampling is not required in young patients with severe hyperaldosteronism and a lateral mass. That is again a correct statement, because in elderly patients, you are more likely to get adrenal incidentallomas or adrenal adenomas which are not functional. But if you are getting an adrenal mass in a young patient, it is more likely to be the culprit lesion. And if you have severe hyperaldosteronism evidenced by aldo levels more than 20 to 30 nanogram per dl to go with it, with hypokalemia as well, then you are almost definite that it is that lesion that is visible which is responsible for aldosterone overproduction. So again, that is a correct statement. Patients with bilateral hyperplasia are younger than those with aldosterone producing adenoma. That is a wrong statement. The bilateral adrenal hyperplasia corresponds to around 60% of all cases of primary aldosteronism, and aldosterone producing adenoma 30 to 40%. Bilateral hyperplasia, they are older individuals, they have less severe presentation with lesser chance of hypokalemia. 25% patients with hyperplasia would be having hypokalemia, whereas 50 to 60% of those with adenoma would be having hypokalemia. So aldosterone producing adenoma individuals would be younger, more severe disease with higher chance of hypokalemia. And fourth option, during AVS, venous sample for left side is obtained from the left inferior phrenic vein, because it is not always possible to cannulate the left adrenal vein, and the phrenic vein and the adrenal vein combine together to form a common trunk called the phrenico-adrenal trunk. It is from this area where you collect the sample for left side from. Whereas the right adrenal vein is directly cannulated, whereas the left adrenal vein, you cannulate the phrenico-adrenal vein or the inferior phrenic vein. So the next question, a 42-year-old male with coarsening of facies and enlargement of hands and feet. Now the diagnosis is evident at this point itself. What is it? It is acromegaly. Which of the following is not true regarding the evaluation of this condition? That is acromegaly. So oral glucose tolerance test is the gold standard, the correct statement. Serum IGF-1 has high sensitivity for screening in diabetes subjects. That is actually the wrong statement. Why? Because for growth hormone to result in IGF-1, there are certain other factors also which is required, like insulin, testosterone, thyroxine, etc. Okay, so in a patient who is having uncontrolled diabetes, you are actually having less amount of insulin in portal circulation. So in the liver, less amount of insulin would be available, or there would be insulin resistance. So even if there is sufficient amount of GH, all of that will not be able to translate into IGF-1 production because of low insulin action, due to which even in patients with active acromegaly and uncontrolled diabetes, their IGF-1 may not be as high as expected due to this phenomenon. Hence, the sensitivity of IGF-1 is down drastically in a patient with uncontrolled diabetes. So that is a false statement. MRI is more likely to show macroadenoma, which we have discussed. IGF-BP3, just like IGF-1, can also be used as a screening investigation. So the causes of acromegaly can be either due to GH or GHRH, which again can arise from the pituitary or from the extra pituitary sources. The most common is the GH producing macroadenoma from the pituitary. That is the most common cause. The external appearance, you have coarsening of the facial features along with the extremity enlargement. The screening investigations is IGF-1, and the definitive is oral glucose suppressed GH. Oral glucose suppressed GH is the definitive investigation. Next question, enzyme mediating the inactivation of cortisol at the level of renal tubules. So we have seen about 11 beta HSD1, which converts cortisone to active cortisol, whereas you have the 11 beta HSD2, which converts cortisol to cortisone. The cortisol is the physiologically active glucocorticoid, and cortisone is its inactive form. So this enzyme is produced in those areas where you don't want excessive glucocorticoid action. So which are those areas where you don't want excessive glucocorticoid action? It is the area where mineralocorticoid receptors are present. So mineralocorticoid receptors can bind both aldosterone and cortisol. Surprisingly, both of these ligands have equal affinity to the mineralocorticoid receptor. But you know that the cortisol concentration is 100 times higher than aldosterone at a particular area, right? So obviously, two molecules with similar affinity and one having 100 times higher concentration, what do you expect? Cortisol to always win over aldosterone. But due to the presence of this enzyme 11 beta HSP2, it will inactivate the cortisol to cortisone. Thereby, the binding affinity reduces. The cortisol concentration is also reduced. So, which are the areas where 11 beta HSP2 is present? It is those same areas where aldosterone receptors are present. So, they are renal tubules, that is the kidney, the colon, and salivary glands. Function we have learned and clinical significance. So what happened when the 11 beta HSP2 enzyme is inactive or is inactive either due to genetic causes or due to acquired causes? Then the cortisol will be able to overpower the aldosterone. It will bind to mineralocorticoid receptor. And what will be the result? The patient would be having hypertension, hypokalemia, and metabolic alkalosis. So this triad of features, which is similar to primary aldosteronism, can occur in patients who have inhibition of 11 beta HSP2 enzyme. So this aldosterone usually competes with cortisol to bind to mineralocorticoid receptor, and this condition is what we call as apparent mineralocorticoid excess. Apparent means you have features of mineralocorticoid excess, but it is not due to aldosterone. It is due to the cortisol binding to the mineralocorticoid receptors. So what are the causes for that? The genetic causes include the 11 beta HSP2 enzyme inactivating mutation. Then the acquired causes like the licorice consumption and carbinaloxone, which is a drug whose side effect is 11 beta HSP2 inactivation. There also the patient can have similar clinical profile. Now, the next question, which of the following is not true regarding secondary adrenal insufficiency? So whether secondary adrenal insufficiency is the most common AI in clinical practice, it is a true statement. The steroid use, exogenous steroid use resulting in HPA axis suppression is the most common cause of adrenal insufficiency in clinical practice. Hyponatremia is unlikely. We have learned that the sodium lowering in adrenal insufficiency is contributed by both aldosterone and glucocorticoid, whereas the potassium is influenced mainly by the aldosterone only. So hyponatremia is unlikely is a false statement, and it is a very common presentation of secondary adrenal insufficiency. Salt craving is absent, which is a true statement due to intact aldosterone production. And TBL1X, it is actually the new name for the TPIT transcription factor, which can result in isolated secondary adrenal insufficiency. Which of the following is not a cause of hypertension due to increased aldosterone pathway downstream signaling? Now, aldosterone pathway components include the ligands. So we have just learned what are the ligands. Can be either aldosterone itself or cortisol. Okay, then the ligand bind to the mineralocorticoid receptor. Mineralocorticoid receptor causes a downstream signaling which eventually activates the epithelial sodium channel. So these are the three essential components of the aldosterone pathway. Now let's look at these conditions. What do you mean by Liddle syndrome? So Liddle syndrome is one condition where the epithelial sodium channel is constitutively active. ENaC channel is active. So whatever features you are seeing with primary aldosteronism, that triad, will be seen with Liddle syndrome itself, but the only difference is aldosterone levels will not be high because the ENaC activation is due to a mutation in that channel subunit itself. So this condition is inherited in an autosomal dominant fashion. The patient would have hypertension, hypokalemia, and suppressed renin with suppressed aldosterone levels. So that is actually a pathway, aldosterone pathway disorder itself. Now, what do you mean by saying syndrome of apparent mineralocorticoid excess? We have seen the cortisol, which is not inhibited by the 11 beta HSD2, acts on the mineralocorticoid receptor, activating the receptor pathway. So again, it is a true statement. Now, what do you mean by Geller syndrome? So Geller syndrome is actually an activating mutation of the mineralocorticoid receptor. Activating mutation of the mineralocorticoid receptor, where it is exquisitely sensitive to progesterone. So the progesterone in the body can stimulate the mineralocorticoid receptor to produce hypertension, hypokalemia, and all the features of primary aldosteronism with a suppressed aldosterone levels. So which is the condition where you have sustained high progesterone levels, pregnancy. So a pregnant individual presenting with these features, you should think of the possibility of Geller syndrome due to activating mutation in the mineralocorticoid receptor. And finally, what is Gordon syndrome? We have seen Gordon syndrome is pseudo-hypoaldosteronism type 2 due to WNK4 gene mutation, which causes overaction of the sodium chloride supporter, and its action is independent of the mineralocorticoid action pathway. So Gordon syndrome is the answer for our question. So next question, which of the following is not true regarding regulation of growth hormone secretion? Again, a straightforward question. So all these are related to the regulation of growth hormone, the levels, which are the factors that stimulate or inhibit the growth hormone levels. So levels increase during NREM and reduce during REM. It's a very true statement. The growth hormone levels are reduced in obese individuals. Again, correct statement. Why? Because the obese individuals have more of insulin-induced IGF-1 generation, which will have an inhibitory effect on the growth hormone levels. IGF-1 levels exert a feed-forward stimulation, which is a wrong statement. Why? The two important factors that suppress the growth hormone are the IGF-1 and the somatostatin. Okay, so if you look at the factors that regulate the growth hormone levels, you can see the IGF-1, the hypothyroidism, free fatty acids. This SRIF is the somatostatin. So these are the things that inhibit the growth hormone. Amino acids increase growth hormone. The glucose and fatty acids in the food reduce the growth hormone. So amino acid it increases, glucose and fatty acid reduces the growth hormone. And highest levels during the NREM stages. Alpha adrenergic and cholinergic stimulus increase growth hormone. Beta adrenergics reduce the growth hormone. So which of the following is not true regarding Pheochromocytoma? So plasma catecholamine levels are most sensitive for diagnosis. So let's see. So what do you mean by plasma catecholamine levels? So catecholamine means epinephrine and norepinephrine, or adrenaline or noradrenaline. So catecholamine means that compound that harbors a catechol ring. Okay, the catechol ring. And it is worthwhile mentioning that previously we were using the serum epinephrine, urine epinephrine, norepinephrine, urine norepinephrine, all for the diagnosis of Pheochromocytoma. But now we are not using it. Why? Because these perfectly formed metabolites are released only intermittently from the adrenal tumor. This epinephrine and norepinephrine are released only intermittently. So if you test the serum of the patient to check for plasma epinephrine, even if the patient is having Pheochromocytoma, if there is no active production because it is produced in bursts, the test will turn out to be negative. So we wanted a better marker. That's why we have looked at metanephrine and normethanephrine. Why is meta and normethanephrine a better marker? because within the tumor tissue, this epinephrine is continuously converted into metanephrine, and norepinephrine is continuously converted into normetanephrine. And the release of these molecules into circulation is continuous rather than intermittent. So whatever time, if you are collecting the sample, you would have higher levels of metanephrine and normetanephrines if the patient is harboring a pheochromocytoma, and it is not possible if you are estimating epinephrine and norepinephrine. So metanephrine and normetanephrine doesn't harbor an O catecholamine, and so they don't come under the category of catecholamines. So coming to the other options, headache, palpitation, and diaphoresis are of course the classical triad of pheochromocytoma. The clonidine suppression test is used as a biochemical diagnosis. So clonidine suppression is nothing but the clonidine being an alpha 2 agonist, it reduces the sympathetic output. So false positive elevation due to sympathetic overstimulation can be avoided. So if the norepinephrine levels are still elevated despite giving clonidine, then you can rule out the other false positives due to sympathetic overstimulation. And alpha blockers are indicated in all patients with pheochromocytoma. It doesn't matter whether the patient is having a significant hypertension or not, you will give alpha blocker, because theoretically, even the patients without hypertension can develop hypertensive crisis during surgery. That's why you give alpha blocker pre-treatment for all pheochromocytoma diagnosed patients. So option A is our correct answer. Plasma catecholamines are not the ones that I use. Metanephrine and normetanephrine, which are not actually catecholamines, are the metabolites that we use for diagnosis. So the next option, urine-free cortisol is not useful for monitoring of a patient taking which medication of Cushing syndrome. So monitoring of Cushing syndrome therapies, as you know, you have three types of drugs. You have the pituitary directed drugs like the pasireotide, then and cabergoline. You have the adrenal directed drugs like ketoconazole, metorapone, mitotane, oscillotrostat, etc. Then you have the receptor directed drugs. So for pituitary and adrenal directed drugs, you look for cortisol levels. Cortisol levels are used for monitoring the pituitary and adrenal directed therapies. And for receptor mediated drugs, already they are blocking the action of cortisol. So the cortisol levels are bound to be high. So you cannot make use of the urine-free cortisol or salivary cortisol because they will always be high. So what we will look at is the clinical improvement, mainly with potassium, the blood pressure, the glucose levels. So these end organ effects are what is being monitored in a patient who is on glucocorticoid receptor blockers. So here, which is the glucocorticoid receptor blocker among the list? It is the Relacorilant. So Relacorilant and mifepristone, we are not using this cortisol-based testing for monitoring its efficacy. I hope the explanation is clear. Now, all of the following are true statements regarding the use of Mitotane therapy in adrenocortical cancer, except, again, this is a direct pick from Harrison. The minimum duration of use is 2 years, correct statement. Result in hypothyroidism and hypoadrenalism, again, that's a correct statement. Other important side effect is the CNS side effect like sedation, ataxia, peripheral neuropathy, etc. The patient requires hydrocortisone and fludrocortisone in most cases. That is actually wrong. Even though this mitotane is an adrenal cytolytic agent, that means it causes destruction of the adrenocortical cells, the zona fasciculata destruction is much more common than zona glomerulosa. That means in some cases they may require both hydrocortisone and fludrocortisone, but usually the patient would have deficiency in the glucocorticoid level only, and they would have intact mineralocorticoid function. So in most cases, the combination is required is actually a wrong statement, and hydrocortisone is the one which we initially start. So despite being on hydrocortisone, if the patient is having features of mineralocorticoid deficiency, then only you will add on fludrocortisone. And it causes an increase in cortisol binding globulin level, very, very important. So in a patient who is on mitotane therapy, you will not be using overnight dexamethasone suppression test, midnight plasma cortisol, So total cortisol based test will not be useful in a patient with Mitotane because the cortisol binding globulin will be high. So if you are using the total serum cortisol, the levels would be high. So which is the preferred modality of monitoring? Urine-free cortisol, or salivary cortisol, because these two are free cortisol based indices. So either you use salivary cortisol or use urine-free cortisol in a patient who is already on Mitotane. So this is points which we have discussed regarding Mitotane. The treatment should be given for at least 2 years. Therapeutic concentration is 14 to 20 milligram per liter. The side effects include sedation, hypothyroidism, hypogonadism, adrenal insufficiency, hepatitis, etc. So coming to the last question of our today's discussion. In a patient with primary adrenal insufficiency, which of the following conditions does not mandate an increase in fludrocortisone replacement? So in effect, the question is meaning that which are the conditions where you require higher doses of mineralocorticoids? So in our body, there is no compensatory increase of mineralocorticoids during fever. Okay, during fever and stress, there is no compensatory increase in mineralocorticoids, but there is 2 to 3 fold increase in the glucocorticoid production, but no such increase is mirrored in mineralocorticoids. So which are the conditions where mineralocorticoid requirement increases? In patients where you're having losing excessive water, as in hot climate, in prolonged strenuous exercise. In phenytoin treatment, phenytoin actually stimulates the metabolism of fludrocortisone. That's why you will have to increase the fludrocortisone dose. It's not because our the body's mineralocorticoid production increases with phenytoin treatment, but is actually it will degrade the fludrocortisone faster, due to which you would have to give higher doses of fludrocortisone. So the answer for this question is fever. Fever requires increase in the glucocorticoid dosage, but not in fludrocortisone replacement. So that is all regarding today's discussion. Thank you.